Hi, my name is Dr. Don Buford. I am a sports medicine fellowship trained orthopedic surgeon based in Dallas, Texas. Been in practice now for 21 years, and I'm excited to bring some evidence-based orthobiologics uses and clinical outcomes data as it pertains to spine applications. I'm going to focus on platelet-rich plasma and bone marrow aspirate concentrate. I'd like to give a heartfelt thank you to Dr. Fetter and the organizers of this symposium for the invitation to participate. These are my disclosures. I'm the director of the Las Vegas MSK Ultrasound and Orthobiologics course. This is a hands-on training course that we've had since 2008. We now have it twice a year in Las Vegas in January and July. I'm one of the founding editors of the Biologic Orthopedics Journal, along with Bill Murrell and Alan Mishra. And this is a journal that accepts basic and clinical science research in the field of orthobiologics. I am the immediate past president of the Interventional Orthobiologics Foundation, and I am still a current board member in that organization. I am either a consultant or in the speakers bureau for multiple companies, including Trice Medical, Globus Medical, and Arcuro. So this is the question that all of us in orthopedics need to start asking ourselves if we haven't already. Why orthobiologic therapy? Why do I need to incorporate this into my practice, or at least be knowledgeable about its potential benefits? And the simple answer is there's mounting evidence that some of these orthobiologics may be safe and effective for multiple orthopedics uses. And we're no longer just talking about as a surgical adjuvant to create a fusion or to treat a non-union or a malunion. We're now talking about using orthobiologics as a primary treatment modality for many orthopedic conditions. My experience, I've been using orthobiologics since about 2008. And at this point in my practice, 80% of the time I am using platelet-rich plasma. 20% of the time I'm using bone marrow concentrate. The reason for that in my practice is because I try and stay evidence-based, and of course I try and stay regulatory compliant. And the evidence at this point, in my opinion, doesn't really support using bone marrow concentrate for every particular orthopedic condition. We still need more data. However, the data for platelet-rich plasma is becoming very strong, and in many situations is actually a higher level of data than what we have for surgical alternatives or for other injection-based treatment alternatives like steroid shots. One of the difficulties in assessing this autologous treatment as a drug is that it's not all the same, right? Every patient doesn't come in with the same platelet count. Every procedure doesn't lead to the same platelet dose. There are multiple commercially available, 510K cleared devices on the market. And so it becomes our responsibility as clinicians to dive into this if we're going to be offering this to patients, to make sure that we're offering them a state-of-the-art, evidence-based, clinically effective version of PRP. A little bit about dosing. I think more and more evidence and more literature is going to support the concept that dose does matter for PRP, just like it matters for virtually every other drug. There's going to be a certain dose response curve. We're still trying to sort it out for every condition where we use PRP. But here's just an example. These two drugs are both autologous PRP. If we start with a platelet count of 200, which is basically an average human platelet count, the PRP on the left that we call drug 1 is made from a 10 cc blood draw. We inject 5 cc's of leukocyte-poor PRP. The concentration is really just 1.5x, but we have to go a little bit deeper to quantify this. When you quantify that 1.5x concentration equates to a platelet count of about 350. And if we're injecting 5 cc's, that makes the platelet dose 1.75 billion platelets. And that's the number that I think we're going to start seeing more as we quantify PRP. That, of course, plus the leukocyte or granulocyte content and maybe a few other parameters. But the platelet dose is important. Drug number 2, also called PRP, is made from a blood draw that's 6 times larger than drug 1. So now we have a 60 cc blood draw. On balance, that's 6 times more platelets just at the outset. If we concentrate down to 5 cc's, that gives us approximately a 5x concentration, for example, and a platelet count that may be in the range of 1,500 versus the 350 from drug one. If we multiply that by the same 5 cc's of PRP that we inject, that is now a drug that has a dose of 7.5 billion platelets. Those are two very different drugs. They're both called PRP, but they're not the same at all. And there's more than likely going to be different situations where drug one may work. At this point, in my opinion, we're still at the phase where drug two or more is still better for most orthopedic applications, because what we see is with the higher dose PRP, patients are getting more pain relief for longer and better functional outcomes as well. One of the things that I think is important is to understand what is the level of evidence that we should demand before we start to incorporate these new procedures, new drugs into our clinical practice. For years and years at meetings like this, in the orthobiologics section or in the new, on the horizon section of these meetings, people will always say, we will start using that when there's higher level evidence. And it prompted me one day to sit down and sketch out an idea for a quick little research project that we subsequently published. And all we asked was, what is the average level of evidence in the major orthopedic journals? And so I selected 6 of the top 10 orthopedic journals. These are selected based on their H5 index scores. And these are all journals that you're familiar with: AJSM, Clinical Orthopedics and Related Research, JBJS, KSSTA, which is Knee, Surgery, Sports, Traumatology, and Arthroscopy, the Green Journal of Arthroscopy, and the Journal of Shoulder and Elbow Surgery. These 6 journals, most of us read at least one of them on a somewhat regular basis. And over the course of 13 months, I looked at over 1,400 papers that were all clinical research papers. Had 2 helpers that were fantastic. And what we found after crunching the level of evidence for all of those 1,425 papers was that the average level of evidence across these journals was 3. And the important thing about that is one journal wasn't necessarily better than the other in terms of level of evidence. So the average level of evidence in core was 3. The average level of evidence over the same 14-month period in JBJS was 3. The average level of evidence in the Journal of Arthroscopy was 3. And so that is a case control study. Those are typically retrospective comparative studies. And it was a little bit surprising because most of us carry around, I think, a preconceived notion that JBJS only publishes level 1 studies, or that Journal of Sports and Journal of Sports Medicine, only publishes high level data. And that's just not the case. Many of us, most of us, if not all of us, make clinical decisions and surgical decisions every day based on data that is not from a randomized, double-blinded controlled trial. The take-home message is that we shouldn't hold orthobiologic research to a different standard that we accept in the rest of orthopedics. Now let's look at some of the data as it pertains to spine. So when we're talking about platelet-rich plasma, you will see that there's 3 or 4, maybe even 5 spine conditions where we have high-level data, level 3 or higher, that PRP is an effective treatment option for these patients. In 2020, this paper on the left, which is a level 3 paper, looked at the effectiveness of ultrasound-guided PRP injections for SI joint dysfunction. They had 50 patients in the study group, and what they discovered was that PRP gave a 2-point pain score decrease that lasted for these patients out to 1 year. And so remember that 1 year seems to be kind of the point at which some of these clinical benefits start to taper off when we're talking about PRP. And here's the first paper that I'm going to discuss where that 1 year time interval comes into play. These authors also noted that PRP gave a 10% functional score increase from 1 month to 1 year. So in a nutshell, that sums up most of the research: decreased pain, increased function, somewhere between 10 to 12 months. In 2016, another study was published looking at the same clinical question. In this example, they actually compared PRP injections to steroid injections, so we have more of a comparative study. This is a level 1 study. Group 1 was depomedrol and lidocaine. Group 2 was leukocyte-poor PRP. And what the authors discovered was that by the 6-week mark post-injection, the leukocyte-poor PRP group was doing better than the depomedrol group. Furthermore, what they found at 3 months was that 3 out of 4 patients that had the depomedrol injection for SI joint dysfunction, 3 out of 4 were no longer getting adequate pain relief, whereas 9 out of 10, or 90% of the patients that had leukocyte poor PRP injections for their SI joint dysfunction were still having significant pain relief. We're still satisfied with the procedure. And so that was highly statistically significant. So that's another clinical example that we can use to backstop and justify using PRP for SI joint dysfunction compared to steroid. Caudal epidurals, there's been a fair amount of literature using PRP as the injectate and quantifying clinical efficacy. This is a level 1 study that was published in 2020 in the Journal of Pain Practice. This was a randomized, double-blind, controlled study, 50 patients in the study. Notice that the blood draw, they did a nice job letting us know what they did. This was a 60 cc blood draw. So in my mind, I'm thinking, okay, this is likely high dose PRP. And what they discovered was that corticosteroid patients did better on their pain scores at 1 month. But by the 3-month mark, the patients that had leukocyte-rich PRP injections were doing better than the corticosteroid injections. And that difference was still present at the 6-month mark. So just another example, patients were doing epidural injections, a particular version of PRP, in this case, leukocyte-rich PRP, was shown in this study to be better than corticosteroids starting from 1 month going forward. And that's another kind of pearl in these orthobiologic procedures, is there is a bit of a ramp up time, right? That it isn't immediately effective like lidocaine or ropivacaine or even a steroid might be. So most of these patients don't report onset of pain relief or functional improvement until they hit about the 2-week to 4-week mark. And so that's something we can use clinically as we counsel our patients that are considering these procedures. Lumbar facet joints, this is another target for platelet-rich plasma injections for symptomatic patients. In 2016, we have a level 2 study with 46 patients. And in this study, we're comparing 5x leukocyte poor PRP, so essentially high dose PRP versus steroid lidocaine injection for facet joints. What the authors found, and this is a group of Chinese authors, was that both groups of patients had improved pain scores and ODI and RMQ functional outcome scores. But here's the key. The steroid group peaked at 1 month and the rest of it was downhill. The leukocyte poor PRP group, not only did they improve and they were doing well at 1 month, they continued to improve all the way through the 6-month follow-up period in this study. So yet another example documenting that orthobiologics take a little bit of time to ramp up. And unlike most of our patients that have steroid injections, the length of benefit from this particular orthobiologic injection seems to be measurably longer than the benefit from a steroid injection. Cervical facet joints, yet another example where PRP is effective. In this level 3 study that was just published this year, these patients had a single injection of PRP and 3-month follow-up. Most of these studies don't admit patients into the study until they've already failed other non-invasive, non-operative measures. So it isn't like they're just taking patients that walk in and say, my neck started hurting yesterday. These are patients that haven't gotten better with the typical standard of care treatments. And now they have this enrollment into the PRP study. And so in these patients, 70% had significant pain improvement at 3 months. 80% had significant NDI score improvement or functional improvement at 3 months from a single injection. The last line here is a little bit wordy, but if you think about it, it makes perfect sense. 41% of the patients in this study still reported at least 50% of pain relief at 3 months. And so let me say that again, 40% of the patients had at least 50% pain relief at 3 months. The lumbar disc is an area where we have a lot of orthobiologic data in the literature. In this example, we are doing intradiscal PRP injections, and this is a level 1 study that was authored or chaired by Greg Lutz and his colleagues in New York. They used the Harvest Company's version of PRP versus a contrast agent for control. This was a single intradiscal injection, and again, level 1 study. And what they found was that the group that had the PRP injections were significantly better in terms of their pain and function at 2 months. So by the 2-month mark, the PRP group had pulled ahead of the control group. And those PRP outcomes were durable out to 1 year. Patients 1 year later were still reporting statistically significant improvement in their pain and in their function. So now let's change gears and talk about bone marrow concentrate. This is a little more controversial only because we have less data. And that's why in my practice, I'm using PRP 80% of the time, bone marrow concentrate 20% of the time. Not because we have data showing that that's what the ratio should be. It's just that we only have, in my opinion, clinically significant outcomes data justifying BMC use in about 20% of the procedures I do. So here's an example, or really just an editorial comment. All of the patients that we talk with about orthobiologics want to know if BMC is safe. They're scared about potentially having a stem cell procedure transfer some sort of malignancy. And we have 30 years of data that BMC is safe in orthopedics. And I know I'm preaching to the choir at a spine meeting where bone marrow and bone graft is used, so often in spine procedures. And so this is not a tough audience to convince that bone grafting is safe. And in a similar fashion, bone marrow concentrate is safe. One of the pearls that I try and get across to people that haven't really used a lot of BMC is that concentrating bone marrow is important. It is worth taking the step to concentrate the bone marrow, just like we concentrate blood to make platelet-rich plasma. And the simple reason is that concentrating bone marrow raises the cell count. And at least at some level, the cell count in this procedure is likely clinically significant. It is clearly, in my opinion, it's clearly not the only important parameter. So there are many, many other things in a BMC injection that are clinically important and may be responsible for the success of the procedure. We don't even know them all. But the bottom line is, we do know that in many studies, the cell count, which is the dose in this example, the cell count does matter. And since it matters, to me, it's worth taking the extra 15 to 20 minutes to spin the bone marrow aspirate around and create bone marrow concentrate. It also gives us the added advantage of getting rid of the red blood cell content and also creating a separate plasma stack that we could then dehydrate and further concentrate some of the large proteins. And we'll talk about that in a minute. So if it's not just stem cells, what else matters? The two main things that I'll talk about in this presentation are IRAP, which is a very, very powerful biologic anti-inflammatory agent. IRAP stands for interleukin-1 receptor antagonist protein. And functionally in the body, it functions as a very potent anti-inflammatory, amongst other things. A2M is alpha-2 macroglobulin, and amongst other functions in the body, it is a protease inhibitor. So it stops some of the bad actors that are in our joints and in our soft tissues that are breaking down soft tissues. So A2M, in large part, stops catabolic processes. And that's good. We don't want to lose more cartilage. We don't want to have tendons further degenerate. And A2M is responsible for making that happen for us in many ways. BMC is very different from PRP, and that's another common question that I get from clinicians and patients alike. IRAP, which is that anti-inflammatory that we know about, is much, much higher in terms of concentration in BMC, up to 20x. And so if you have a patient who has an inflammatory condition, there's a good chance you could make a clinical argument to at least consider BMC as a treatment option, because BMC is very anti-inflammatory, even more so than PRP. And so this was a study published in 2019 in AJSM that just confirmed earlier data that had been published by authors like Brian Cole and Lisa Fortier, showing that IRAP is a much higher concentration in our bone marrow than in our blood. So this is one of the areas where we have good data that BMC is effective as a treatment. The lumbar disc, just like we had PRP data for lumbar disc, we do have BMC data for discogenic back pain. This is an interesting study. This is kind of a longitudinal follow-up study where this group of patients initially entered the study having been told that they were discectomy candidates. And so these 26 people entered the study. They had a single injection of autologous BMC, and in 3 separate publications, starting at 1 year, 2 years, and then at 5 years, this same cohort of patients continued to have significant functional improvement and less pain all the way out through 5 years. And one of the nice aspects of this study that was kind of chaired by Ken Patine and included Matt Murphy, who's a PhD biologist, and as is Richard Suzuki and Ted Sand, what they discovered was there was a cutoff in terms of dosing where in the patients that got more than 2,000 CFUs per milliliter, they seemed to do better. So this was a nice attempt to start to define a dose-response relationship. But the real take-home message for a spine surgeon or for any clinician is that all 26 of these people had valid, legitimate findings on imaging and on physical exam that supported a recommendation for discectomy, for surgery. And yet, after this single injection at the 5-year mark, essentially only 1 out of 4 had actually had the surgery that was recommended because the other 3 were doing well. And this injection seemed to alter their disease state and allowed them to be functional. And the cost of that was $5,000. So again, it's cash pay, at least for me. I think it's still best addressed as a cash pay procedure. It's not covered essentially by commercial insurance in the United States. But at that price point, if you took that to an insurer or to a company or even to a patient and said, look, for $5,000, we can get you 5 years down the road, 75% chance you're not going to need that surgery that you would otherwise need. A lot of people would be responsive to that and would take advantage of that treatment. The cervical disc is another area where BMC has some published data. This is a level 2 study that was published in 2017, and it has 2-year follow-up, which is nice. And the key here is that this documents kind of the ramp up period before these procedures start to work, right? So here by the 6-month mark, regardless of how many levels were injected, by the 6-month mark, all of these patients had received or reached essentially their maximal level of improvement. And on this graph, in terms of their pain, on the VAS graph, their pain stayed down, stayed effectively treated for 2 years. So that's another outcome metric that we measure that I think at this stage in this field, I think saying that most of our BMC injections are getting patients 2 years down the road is a fair thing to say if we're treating an area where we have this data. This is just a functional improvement measure, and it shows that their functional improvement also stayed in a good range. They were better for 2 years from this single injection. So what about SI joint? We don't really have any BMC data for the SI joint. So those of you that are doing it, please keep the data. Please collate it and write it up and submit it so the rest of us can learn from you. Same thing, lumbar facet joints. We just don't have any significant studies showing that BMC is effective for lumbar facet joints. That doesn't mean it doesn't work. I actually believe that it will. If nothing else, just based on the anti-inflammatory capabilities, we just don't have enough peer-reviewed published literature to make a slide. Same thing with cervical facet joints. Caudal epidurals are another application in the spine where we just don't have enough published data to recommend using BMC. Doesn't mean it's not effective. It just means that we need more data. So the evidence is clearly growing, and it's growing rapidly, that orthobiologics is going to be a valid treatment option for many, many spine conditions. It's not going away. The data is only strengthening the clinical recommendations for certain conditions. We have to be critical in our data collection, and we have to be critical in our orthobiologic descriptions so that we can really keep pushing the ball towards the end zone here. And I really believe the collaboration will accelerate all of our acceptance and our patients' acceptance of these orthobiologic treatments, and it will improve our clinical outcomes. Thank you very much.